Hello, my name is Mark A. Bell. I'm a family physician, a professor at the University of Georgia, and a former member of the U.S. Preventive Services Task Force. My comments today are those of mine alone and do not reflect any endorsement of the U.S. Preventive Services Task Force, and I'm not speaking on their behalf in any way. This is part of the general practice modules for the Royal College of Surgeons in Ireland, and I did this work as an RCSI Fulbright Scholar in 2019. However, I think the general information provided is completely relevant outside of the Irish context. There are a few Irish-specific things, but mostly it's relevant to pretty much any country you want to talk about screening in. Here are the learning objectives. Take a moment and scan them. We want to define screening, how it's different from diagnosis. Think about the potential benefits and harms and how to measure benefit. Think about key measures of accuracy and why it's important to consider prevalence when we're thinking about screening, because in screening, disease is often quite rare. Think about special challenges of screening like lead time bias, length time bias, healthy volunteer bias, and overdiagnosis. Talk about the national screening recommendations for Ireland, including starting, stopping ages, intervals, and the recommended tests. And then apply what you've learned to the example of breast cancer screening. The first module is about criteria for assessing a screening test, provides some general background, and also digs a little bit into how we assess and measure potential benefits and harms. So Sir Muir Gray said all screening programs do harm, some do good as well. It's a bit backwards from what you might expect, because there is a general sense in the population and also among healthcare professionals that screening is always a good thing. We have to remember that when we take somebody who's healthy and happy and asymptomatic, that if we start doing things to them, they may lead to adverse consequences like an unneeded biopsy or an unneeded surgery. We're going to talk about those harms, and that person may not benefit at all. So anytime you screen someone, there's the potential for harm. There's also the potential for benefit, and we have to make sure that benefits outweigh harms, and that's going to be a theme of this presentation. Let's begin by getting a piece of paper and a pen and jotting down your answers to these three questions. We're going to review the answers later on. First, for which cancers is free screening offered in Ireland? Second, how likely is it that an average risk woman dies of breast cancer? Third, Mary gets mammograms every other year from 50 to 69, while her sister Maeve does not. How much less likely is Mary to die of breast cancer than Maeve if they both live a full life? So write those answers down. Pause if you need to in the presentation to write them down, and then unpause and play when you're ready to proceed. So screening is defined as using a test to identify preclinical disease in an asymptomatic person. Typically, we're targeting an entire population, like all women age 50 to 69, or all men and women age 50 to 75, or some other broad, large population. It's really important to remember that they are asymptomatic. They don't have any bleeding or lump or pain. And that's important because people who are symptomatic, who present with rectal bleeding or a lump in the breast, are more likely to be willing to accept the burdens and potential harms of the investigation, the diagnostic investigation, than someone would be who's perfectly healthy and happy and has no symptoms, which is the case in screening. So why do we screen? Pause if you need to for a second and think about what's the first thing that comes to mind when I say, why do we screen? Well, most people, and I've taught this stuff for a long time, most people will say to detect disease early. But that's only part of the answer. It's not to increase survival from diagnosis, as we'll learn later. And we screen for disease to decrease mortality from that disease without causing more harm than good. So that's really why we are screening. It's not just to detect it earlier, but that early detection has to actually improve mortality. Not survival from diagnosis, but mortality. So why don't we do the following as screening tests? Colorectal cancer can occur in people in their 20s and 30s, so why don't we do colonoscopy or another kind of screening for colorectal cancer starting at age 20? Why don't we do annual ultrasound for prostate cancer? That's a more sensitive test than the PSA. What about an annual CT scan for pancreatic cancer? We know that's a terrible disease with a high mortality rate. What about an MRI of the head to screen for brain cancer? Think about that for a moment, and then we're going to talk on the next slide about some criteria for screening from the World Health Organization. Pause if you need to. So here are the WHO criteria for screening. These are from 1968, so they're kind of old, but they still guide a lot of screening programs and the selection of screening tests. So, first of all, the condition we screen for should be a major cause of morbidity and mortality. That's really important. We need to be able to also detect the disease early, and treatment for the disease in that early stage improves outcomes, and the outcome is mortality. The screening test should be acceptable, and that varies. To some women, a Pap test is not very acceptable. To many adults, colonoscopy is not acceptable, as evidenced by uptake rates of colonoscopy in the population. On the other hand, a simple blood test may be much more acceptable. There's no point in screening if there's no good treatment for the disease. And the screening should be ideally cost effective. Most health systems have limited resources, all health systems do, and money spent on screening programs is money not spent elsewhere in the health system. The WHO criteria says screening tests should have high positive and negative predictive values, sensitivity and specificity. That's actually not true. No tests are perfect. Screening tests tend to be less accurate than the diagnostic tests, but they have the advantage of being typically less costly and less invasive. So a fecal immunochemical test for colorectal cancer is less sensitive and specific than a diagnostic colonoscopy, but it's also quite inexpensive and convenient. So we trade off accuracy for cost and convenience. The World Health Organization revisited these criteria, and I think if you read through these, there's a much greater emphasis on equity, on evaluating programs of screening and not just tests. What matters is what happens to mortality over, let's say, a 20-year period of screening, not just after a single test. And the overall benefits, the final point, should outweigh the harm of screening. There's a greater recognition that screening can be harmful, and we need to account equally for both benefits and potential harms. So a question, if you want to pause for a moment, is to think about what are the key benefits and the key harms of screening? What are some types of potential harms? So maybe you could take a moment and write down some potential benefits and harms. When you've got at least 2 items in each category, go ahead and advance to the next slide. So here's some potential benefits and harms that I've outlined. Let's begin with the potential benefits. You can reduce disease-specific mortality. You can reduce all-cause mortality, which is even more robust and less subject to how we label the cause of death. And potentially you could reduce morbidity. So if somebody has an earlier stage disease and you can treat that disease more easily with a less invasive treatment, let's say a more minor surgery rather than surgery plus radiation, that's also a potential benefit. What about harms? I mean, there's always a direct harm. It hurts somewhat to have a mammogram, and there's a blood test is slightly painful, very tiny risk of infection, for example. There's radiation involved with mammography and some other screening tests. More importantly, though, are the harms of downstream tests and biopsies. If there's a false positive, a false alarm, then there are costs and burdens and harms associated with those tests, particularly if the patient ends up not having the disease. Cost is important to consider. Screening tests can vary in cost from a few pennies to thousands of dollars. And again, costs or money spent on screening is money not spent elsewhere. False positives can cause worry. They can even cause someone to have a worse assessment of their own health if they've had previous false positive tests. They may feel that they are at greater risk for cancer, even if they're not. There can be unintended consequences. One of the concerns about lung cancer screening is that by doing so, we may decrease the incentive to quit smoking. It looks like that's probably not the case based on data in the US, but it's still, I think, something to always consider. And then there's overdiagnosis, which we'll spend additional time talking about shortly. So here is an example of the potential benefits of colorectal cancer screening. These data are from the U.S. Preventive Services Task Force. And what you see is that for bowel screening, there are two ways that they measure potential benefit. One is by life years gained per 1,000 individual screens, 1,000 individuals screened over their full normal lifespan. Typically in the U.S. we screen from 50 to 75. And at the top is flexible SIG. The next one down is the FIT DNA or Cologuard test. A FIT every year is shown, and various other tests with colonoscopy at the bottom. And I think the main takeaway is that there's a fairly substantial gain in life years per 1,000 persons screened. On average, about 3 months per person. Now, of course, the 3 months aren't spread evenly throughout the population. You have a fairly small number of patients who benefit and who gain maybe 10 or 20 or 30 years of life. The bottom half of the screen shows deaths averted per 1,000 individuals screened, and we see about 20 to 24 deaths averted. So there's a pretty consistent benefit regardless of which test you use and which screening program or you decide to use. About 2 deaths averted per 100 people screened, adding about 11 years of life per person. So pretty substantial benefit. Number needed to screen for benefit of about 50, which is, again, pretty substantial. What about harms? Here we see more variability. The bottom test in each case is colonoscopy every 10 years, and you can see a longer bar, meaning more complications per 1,000 people screened, and of course more colonoscopies over a person's lifetime. The number of colonoscopies is a proxy, I would say, for burden and cost. Complications are a good measure of harm. So the range is about 1.7 to 4.1 colonoscopies per person. Basically, if you start doing colonoscopy every 10 years, you're going to have a lot of colonoscopies. There are also about 0.9 to 1.5 serious complications per 100 persons screened. That's less than the 2 deaths averted, but again, not insubstantial. Here's another way of looking at benefits and harms. This is an efficiency frontier curve. Along the y-axis, we have cancers averted per 1,000 women screened for cervical cancer. Along the bottom, we have the number of colposcopies per 1,000 women performed. Colposcopies are a proxy for harm, burden, and cost. We know that rarely colposcopy can actually lead to scarring, that can lead to an increase in the risk of infertility or preterm birth. What you see as you go from the triangles in the bottom left corner, the color indicates when you stop screening, by the way. So red is you stop at 65, blue you stop at 75, green at 70. The triangle indicates cytology only, and what you see is that as soon as you add HPV testing to cytology, you do see a fairly substantial increase in cancers averted from approximately 16.5 for cytology alone at age, if you end at 65, to about 17.8. So a little more than 1 additional cancer averted per 1,000 women screened. Now, if you start doing that cytology at shorter and shorter intervals, if you change the switch age, if you change the ending age, what you see is that over time, if you go to every 3 years, then every 5 years of combined testing, you greatly increase the burden, the number of colposcopies and cost, but the curve is flat with respect to the y-axis, so there's really no increase in cancers averted. So more frequent screening in this case is not a net good. It doesn't increase the benefit, but it does increase cost and potentially burden and harm. So this is an example where and this is why generally recommended guidelines talk about screening with HPV plus cytology only every 5 years. So how do we measure benefit? A lot of different metrics we could use. Survival from time of diagnosis. 5-year survival is commonly used in cancer treatment studies. All-cause mortality, which is death due to any cause. And disease-specific mortality, which is deaths due to the disease in question. So let's start with survival. Survival is really an illusory benefit. It can make it appear that someone is benefiting from screening when they're actually not. So let me back up a little bit. Excuse me, that's because screening almost always increases survival from the time of diagnosis. When you screen, you will detect the disease at an earlier stage. That's only helpful if life is actually lengthened and mortality is reduced. In the example shown in the graphic, you have 2 lives. In the first, someone is born, they have a cancer detected by screening at age 65, and they die at age 80. The time from diagnosis to death is 15 years. That's a measure of survival from diagnosis. Another person doesn't get screened. The cancer gets larger, causes symptoms before it's detected at age 70, but they still die at age 80. In this case, there's a lead time that's provided by the screening, but it doesn't decrease mortality. The length of life overall is identical. So we should never use measures like 5-year survival from diagnosis when we're talking about screening programs. It's perfectly valid when you're talking about treatment of patients at the same stage of disease, but because cancer screening detects patients typically at a somewhat earlier stage, 5-year survival gives us the illusion of benefit when it may not actually be beneficial. Some people are critical of screening programs and studies that haven't demonstrated a reduction in all-cause mortality. I recently looked at this question with my colleague Kevin Dobbin, and what we found was you actually have to have very, very large studies to detect a reduction in all-cause mortality. So for example, if 10-year all-cause mortality for a population of 65-year-old women is 15%, and their breast cancer mortality is only 1.5%, then that gives us a ratio of all-cause to disease-specific mortality of 10. We can use the graph, looking at the x-axis first, ratio of ACM over disease-specific mortality of 10, draw a line up to the curve, and then go across, and that gives us a multiple of how much larger a study would have to be. In this case, one would need about 8 times as large a study to prove lower all-cause mortality compared to what you need to prove lower breast cancer-specific mortality. The most recent breast cancer screening trial, the AGE trial done in England, had, I believe, 50,000 women in each arm. And so you would need 8 times that number to produce or to be able to see or detect an all-cause mortality benefit. So if we don't see it, it's often doesn't mean that it's not there. It just means that the studies weren't large enough to detect it. So to look at that in a little more detail, this is from the 3 largest recent studies of cancer screening. The first is the AGE study I just mentioned, and what we see is that there are 47 fewer deaths due to breast cancer, and there were 92 fewer all-cause deaths in that population of women aged 40 to 49 during the study period. That's reassuring. The disease and all-cause specific mortality were heading in the same direction. Next example is from the large U.S. lung cancer study, the NLST, the National Lung Screening Trial. Again, disease-specific and all-cause mortality are going in the same direction in this study. On the other hand, in the large UKC tox trial of ovarian cancer screening, we see all-cause mortality increasing while disease-specific mortality was decreasing. So that's concerning. And my argument is that we should when we see disease-specific mortality data and all-cause mortality data, I think we should be reassured if they're heading in the same direction. We should be concerned if they're not. So to wrap up the measure of benefit, first, don't use 5-year survival. If we have all-cause mortality data, that's great, but don't expect it. We may not have large enough studies or enough data. And usually the best option is to focus on disease-specific mortality, double-checking that all-cause mortality is going in the same direction. I just want to wrap up this initial module by talking just a bit about the role of the GP in cancer screening. So the cancer screening in Ireland and in many countries is centrally organized with invitations to screening issued by the National Screening Service. GPs get involved in many ways, though. They may be performing cancer screening tests like the Pap smear. They may be involved in ordering the appropriate follow-up tests when there is an abnormal or positive test result. They can help patients process the information that they get, understanding that screening is not diagnosis, that a positive screening test is not a cancer diagnosis and doesn't necessarily put them at a long-term increase in risk if it turns out to be a false positive. Helping patients deal with those false positives, again, is an important part of the GP's role, who hopefully and often has a relationship and a level of trust with the patient. And then, of course, assuring appropriate treatment for those who are diagnosed with cancer and doing post-treatment surveillance. This ends the first module. Thank you very much.